Okay, you guys, we're going to talk about seizures today. I'm going to start with the application exercise, then we'll go into your slides. All right, so we got a 15-year-old adolescent. Well, first of all, before I go into seizures or into the actual case study, let's talk a little bit about seizures in general. All right, seizures can be partial, local, or focal, and if those three words, you can use them interchangeably. If they would be considered partial, local, or focal, it involves one area of the brain. If it's a generalized seizure, it involves the entire brain. Causes of seizures, 50% are idiopathic, so we have no idea why these kids are having seizures. Some of the other possible causes, it could be an infection, trauma, tumor, an inherited disorder, anoxia, metabolic disorder, lead poisoning. Some of the things we can see with seizures are tonic-clonic movements. The tonic phase is when they're stiff and they actually may stop breathing during this phase. The clonic phase is where we see rhythmic jerking, irregular breathing, and this is when they could actually bite their tongue during the clonic phase. Triggers for seizures could be increased physical activity, excessive stress, overwhelming fatigue, alcohol, caffeine, cocaine, glue. You know how sometimes we see in the pediatric population that kids will huff glue, flashing lights. The big diagnostic for seizures is an EEG. Don't forget your instructions for an EEG. No caffeine before. Wash hair before and after. During the EEG, we may actually cause the patient to hyperventilate, because when we cause them to hyperventilate, they could have a seizure. We actually want to see the brain's activity during a seizure. Some EEGs, we have them come in sleep deprived because we want them to sleep while we're doing the EEG. We want to see what's going on in their brain while they're sleeping. Some EEGs will use strobe lights, again, to elicit that seizure. We want to see the brain activity, what is going on while they're having a seizure. If our patients have recurring seizures, we need to think about precautions. I know we always think about padding our side rails and what we need at the bedside in the hospital, but recurring seizure precautions, you got to think about falls. Do they need to wear a helmet at all times? How often are these seizures? Are there stairs in the home? You have to think about what could happen if they have a seizure and they're close to the stairs. You got to think about water safety. You need to think about sleep. No pillows, no stuffed animals, no close furniture. A lot of times kids with seizure disorders will just have their mattress on the floor. So if they would roll off the mattress during a seizure, they're just having that little kind of bump to get to the floor as opposed to falling off a bed. And then again, like we've said with a lot of other things, it's just constant supervision. The medications that we could use for seizures, monotherapy treatment is the treatment of choice, but in actuality, it's probably combo medications that are needed to control seizures. Basically, what we need to know about the medications is what are they affecting? Some can affect blood cell counts, some can affect the liver function. So if you're on a medication that affects your blood cell counts, you're probably getting regularly scheduled CBCs to see what's going on. And the same with our liver function test. You know, every 6 months, or are they doing it more frequently depending on what's going on with the liver? They say if you're seizure free for 2 years, you can try and wean off as long as you don't have other risk factors. And wean off the medications is what I'm talking about here. The other risk factors would be if they were greater than the age of 12 at onset, if they had a history of neonatal seizures, numerous seizures before control has been achieved, and then any underlying neurologic dysfunction. If you have any of those risk factors, they're not going to try and wean you off the medication. 40% see reoccurrence after the meds are discontinued within 6 months. Some of the dietary factors that we consider, the book talks about a ketogenic diet, creates an increase in ketones, high fat, adequate protein, low carb diet. Before we get into the case study, febrile seizures, they are the most common neurological issue of childhood. And again, febrile seizures, high temperature, 102 to 104. We typically see febrile seizures between 6 months to 6 years. We use Tylenol to treat, possibly diazepam. Boys are more likely. There is a familial susceptibility to febrile seizures, and the cause of febrile seizures is uncertain. All right, let's look at our case study. We have a 15-year-old adolescent admitted to the hospital after a seizure. The adolescent is lethargic, has no previous history of seizures. The adolescent's father tells the nurse that he heard the adolescent grunting in her bedroom, and when he entered, the adolescent's arms and legs were thrashing around and she was blue. He tells the nurse that this lasted about 1 minute, and because the adolescent was difficult to arouse, he called 911. The nurse obtains the adolescent's lab work, which reveals a normal CBC, electrolytes, and a serum glucose of 65. A UA drug screen, those results are pending. What should you do to prepare the room for the admission of this child? Hopefully your mind here went to your seizure precautions. You're going to make the room safe, remove any hazards, side rails up and padded, other hard objects padded and or moved away from the bed, remove any clutter. Waterproof mattress, that's something we could do at home too if our patients did have recurring seizures. Most of the mattresses in the hospital are waterproof. If there's any blinking lights in the room, the strobe lights, you know how when our fire alarms go off, how they have the strobes, you could cover those. And then you'd want suction and oxygen set up at the bedside as well. All right, our next question. Why did the physician order the lab work on this patient? Obviously, they're looking for the cause of the seizure. Can they rule out any other disorders? They're looking for signs of an infection. What's the WBC telling us? We could look for metabolic disturbances as well. And then obviously the urine drug screen, were drugs involved? Did that cause the seizure? The next question, the adolescent calls the nurse on the intercom and tells him she is having a strange feeling. The nurse hears a grunting sound. When the nurse arrives in the adolescent's room, he notes that the child is having tonic-clonic seizures. What does the nurse do next? First and foremost, we always protect the patient, but then we're always recording what is going on. So protect during the seizure, make sure they're safe, record what's going on, what time, how long does it last, what do we see going on. Let's see, if there's any glasses, you'd want to remove them, any hazards, remove them. Allow the seizure to end without us manually interfering. Obviously, we could be calling for help for medications. I'm trying to see here, what else do I have? I got record, time, protect during, obviously with no restraints. What should the nurse do when the child stops? Again, we keep protecting the child after the seizure. We maintain the child in the sideline or recovering position. Call emergency medical services to ensure that the child receives medical evaluation after a seizure. Were there any injuries? Were they in bed? Did they fall? Were they standing? Did they fall? Were they in a chair? Did they hit their head? Obviously, some of our nursing things, vitals, neuro checks, check for injuries. If they did fall, was any other, are there any skin tears? Are there any bruises? Are there any hematomas? Are there any breaks? And then obviously reorient the child. The adolescent is discharged with a prescription for Dilantin. Which of the following statements by the father indicates that discharge teaching has been effective? All right, there's your choice. Oh, sorry, I gotta scroll down. There's your last question there. Okay, so of your choices there, take a look at those. Let's just go through them one by one. I need to administer her medicine in the morning and the evening. That is a true statement. Dilantin should be administered regularly. So regular dosing is kind of what that is talking about there. B, I will keep annual appointments for follow-up on her medication. Annual appointments suggest going once a year. This is a pediatric patient, new onset seizures. We're giving Dilantin. They need more frequent checkups than an annual appointment, so that would not be correct. I will encourage, I will be sure to encourage good oral care and regular dental visits. This is actually true as well. So actually A and C are your answers there. Dilantin can cause unusual growth of gum tissue. So we definitely would want to ensure good oral care. I can't allow her to stop taking the medication after 6 weeks as long as there are no seizures. We kind of talked about earlier when I was going through seizures in general about how and when we would try to wean off. Again, we said no seizure for 2 years, and he's saying 6 weeks. And seizure medication, we would never gradually, or I'm sorry, we would never just stop. We would want to decrease the dosage gradually. We would want to wean them off of it. Some other things that you would want to include in your teaching with any of your anti-seizure medications, anti-epileptic medications. Most of them require blood work. We did talk about the CBC and the liver function, but also specific medications. Dilantin would be one of them. Depakote is another one, Phenobar, possibly Tegretol. We need blood work because you can go toxic on them. So they need to have those levels drawn regularly to make sure, one, that they're effective and therapeutic, but also that they're not toxic. All right, I think that's all I have on seizures. I think I kind of lied when I said I was going to your slides. I'm not going to do that. The general information that I said about seizures before we started the application exercise, you will find those headings in your packet if you want to fill that out. But I included all of my information around my case study. The next thing in your packet after febrile seizures is death and dying. And what I just need to say about that is when we are dealing with the pediatric population and they are actively dying or they have died, we definitely need to reduce anxiety experienced by the child and the family. So that will come a lot from us as nurses, how we are handling the situation. We would want to provide adequate emotional and physical support for the child during the terminal phase of the disease. And we would also want to make sure we're providing adequate nutrition if the child feels like eating. When you're going through that death and dying stage, nutrition might not be at the forefront of our nursing care. It would depend on what the child wants. And again, at this point, it's whatever the child wants to eat. It doesn't matter about high protein, high calorie, whatever they want to eat. And then obviously provide ongoing support for the family. The other thing that we talk about here is dysfunctional grief. If you work in the pediatric setting and you do work with a patient population who could die, you definitely need to be worried about yourself and how you're handling the grief when it comes to a pediatric death. So dysfunctional grief is intense and prolonged feelings of loneliness, emptiness, and yearnings, distractive thoughts, inability to sleep, and loss of interest in daily activities. Obviously, we could see our parents going through these stages as well, but so we need to, if you're working in an outpatient setting and you're working with families, you might need to work on that piece, but you also got to think about it for yourself as well. Nurses may experience personal grief when caring for a child who is dying. Self-reflection and formal debriefing with the staff involved with the situation can help facilitate resolution of these symptoms and feelings. And that debriefing would be more in a pediatric ER or an ER that handles adults and peds. When you get a pediatric patient that comes in and the result of that ER visit is death because of a trauma, something that we did not expect, there is a lot of grief in dealing with that situation. When you work in an area, pediatric oncology, you kind of understand what you're signing up for when you get into that. You know that you are going to see some death and dying of that pediatric population. Not that you become desensitized to it, but you're definitely aware of how you need to take care of yourself and those feelings. So I just wanted to mention that to you guys.